We've got today Martyn Pitman, who is a consultant obstetrician and gynaecologist. I'm Peter Duffy. I'm a whistleblower myself. Obviously, this is the subject we're going to be talking about. And we've also got Helen Hughes here, who is the Chief Executive of Patient Safety Learning. So Helen and I will be sort of taking Martyn through his experiences and really just trying to learn a little more about the phenomenon of whistleblowing in healthcare, how perhaps things could be improved for the future. And I know Martyn suffered quite a lot career-wise as a result of what happened, how we can perhaps get a better culture to stop this sort of thing happening in the future. So perhaps if we could start off, Martyn, if you could just tell us a little bit about yourself, the sort of job you were doing, the whistleblowing, and the sort of retaliation against the protected disclosures that you suffered, please.
Yeah, sure. Well, firstly, thank you very much for inviting me to take part in this today. It's very nice to be invited and to give my sorry tale a platform. So I'm 58 now. I was appointed as a consultant obstetrician and gynaecologist to the Royal Hampshire County Hospital in Winchester back in 2003. I think it was fairly unique in that I was born and brought up in Winchester, undertook my formative education in Winchester, and was fortunate enough during my training to get onto a rotation back to Wessex from London, where I did a lot of my SHO training. And so I think it's pretty unique to be in a position where as a consultant you get to serve the city and the population where you were born and grew up. So it was very much my dream job, really. I always was more interested and had an aptitude and love of obstetrics, but being a district general hospital, we all did both obstetrics and gynecology, but I very much specialised in the high risk obstetrics, labour ward, fetal medicine. I was fortunate enough to be trained in fetal medicine, ultrasound scanning, so I had quite a broad array of obstetric skills, and I was also very interested in fetal monitoring. So I had a lot of training during my formative years under Phil Steer in London. I was fortunate enough to develop an expertise in CTG interpretation, which is obviously the hot topic as far as litigation is concerned in obstetrics. So when the job came up at Winchester, it was the first consultant post I applied for, and I was fortunate enough to be appointed, and it was the proudest day of my professional life when I took up the role there back in 2003. I loved the job. I lived for my work. Looking back now, I made an enormous amount of personal sacrifices to provide what I believe was optimum standards of care to the patients that I had the privilege and honour to look after.
And where do you think things started to go wrong, Martyn?
Well, I think what happened the first sort of decade, so up until probably 2012, I think everything was going pretty well. We were a smallish district general hospital, around 3,000 deliveries, but we punched well above our weight as far as the standard of our obstetric care was concerned, which is why I wanted the job. Compared with other local units, we had very good outcomes. We were very popular with patients, very popular unit to train in as well. So we had a very good standard of trainees that rotated through, and consultant posts when they came up were highly sought after. And then as quite a lot of units of our size around that time, you were vulnerable, and there was this sort of era of to be able to survive, you need to merge with another trust. The units had a very, very different professional ethos. Winchester had very much the traditional sort of consultant-led model, but we had a very positive working relationship with our clinical midwives, and that worked very well. Basingstoke had been pretty much in the first wave of the normalisation process, and perhaps had a more midwifery-led service with less input from the obstetricians. Right. And coupled to that, I'd always staunchly defended the support of informed maternal choice and decision making in obstetrics, particularly around the area of mums opting to be delivered by elective caesarean section rather than labouring, and particularly mums that had previous cesarean sections before. It came up in the recent Ockenden report as being that's the way that modern maternity care should be going to support mum in their choices and how they deliver. So I was kind of a vanguard in that regard, and that gave me a vulnerability with the senior midwives and some of the managers who are very pro normalisation, pro saving costs, and pro trying to get mums to deliver vaginally. So the merger went through, and it became perfectly clear that the way the management structure was going to pan out was that the Basingstoke management was going to be imposed on us at Winchester. And that was compounded by pretty radical cuts in midwifery staffing levels.
Just to clarify things, Martyn, your concern here was essentially over how these births were being managed, and that there was too much of an emphasis on natural birth that was essentially putting mums and babies at risk. Is that a fair comment?
I guess my main concern with the actual merger and how it actually panned out was my concern that we were providing what I thought was a brilliant standard of care at Winchester, and I had a concern that wasn't the case at Basingstoke, and when we merged, that certainly proves to be correct, because we uncovered at the time of the merger that Basingstoke had a whole run of quite serious maternity serious incidents that had been put on the radar of the Strategic Health Authority to be watched.
Who did you involve in your concerns about this?
This has obviously all panned out very badly for me, but I wasn't alone. I naively perhaps took pride in being used as a spokesperson, principally for the senior clinical midwives who basically lost all confidence in their management. So if they had problems, they had no confidence at all in going to their management. But I also acted as a spokesperson for the majority of the consultant body at Winchester, because we felt that the unit was reaching the point where it no longer felt like a consultant-led unit anymore. The midwifery management were making decisions without our consultation. They would come in and find pretty significant decisions have been made without even discussion with us. We were losing midwifery staff. We had increasing sickness rates. And at the turn of 18 into 19, there was a stark realization on our part as consultants, particularly the ones that were doing most of the acute obstetrics, that standards of care were dropping. We were finding inductions of labour. So these were medically complicated labours that we had decided needed to be induced, or being delayed, sometimes for several days, principally because there weren't enough midwives to look after them. And we found the same with elective cesarean sections list as well. We tended to run a very efficient service when we ran before the merger, where we would have lists of 3 elective cesarean sections, ran probably like your urology list used to run, Peter, where you'd have a dedicated team of staff. And the only way it could work is if you got off to a running start, all of the staff were available. And if it worked, it was really efficient and it worked really well. But if it got to the point where it's almost the exception rather than the rule, if you came into work and found that you had a midwife to staff the list.
And Martyn, if I could just go back a few years from when it was merged, and I've worked in many organisations that have merged, and I think the rule of thumb is there's no such thing as a merger. There's always a takeover, and it's always one organisation or one culture that predominates. But I'm just trying to understand some of the issues that you've highlighted. When it was merged, was there an investment in time and effort to get people to work together and develop new ways of working? I mean, what kind of managerial clinical leadership support did you have in the 2 units to try and make that happen?
The point that you make is a very sound one, and it's absolutely apt to what happened. The 2 units, so Winchester and Basingstoke, were a very similar size, around about 2,500-3,000 deliveries, so similar number of consultants. When we merged, there was an absolute pressure led by the management and agreed tentatively by the consultant body that yes, we was sort of cross-site work, and so we were encouraged to do sessions in each other's units, and it became completely impractical, because by the time you travelled up there, if you're only doing 1 session a fortnight, which is what I think I did, you didn't get to know the staff well enough, you didn't get to know the actual department well enough, and it just didn't work. So that didn't last for very long. the consultants, the majority of the consultants got an okay together, but there were very significant differences in the ethos of care, as I've already mentioned, and that produced the friction with regard to decision making. And there was a real pressure to try and make the unit practice to the same standards, practice to the same guidelines, which was never going to work because, we thankfully, as a consultant group at Winchester, adamantly supported informed maternal choice around things like maternal request cesarean sections, whereas Basingstoke put a block on it. So the whole practicing to the same guidelines was never going to work, really. And discussion of clinical incidents was difficult as well, because certainly when we merged, the majority of the adverse incidents seemed to be coming from one unit. So when we started to look at that and appraise that produced the friction as well. It came to a head in March of 2019, and there've been several discussions between a group of our consultant body, and I had agreed, I'd offered to be the spokesperson. So one Thursday, initially meant to be lunchtime, I arranged a meeting with the head of service, so the director of midwifery, who at that time, this is where it gets interesting, because at that time, that individual I viewed as a senior managerial colleague, but I also viewed her as a friend. I'd arranged, ironically, for a junior colleague, a consultant colleague, to come with me, because she agreed with all the points that I was going to make. And then I got caught up with a cesarean section on labour, so I couldn't go. So the meeting was delayed until the evening after work, and unfortunately my junior colleague couldn't come because of childcare. But I didn't even consider not doing on one-to-one, because I'd had numerous meetings with that individual before. So with a meeting of that magnitude, I'd never have, and I never would go into something like that unprepared. So I'd taken a sheet of A4 paper with bullet points on it in ascending level of importance, and I warned the individual before I started that this was going to be quite a challenging conversation. There was stuff on it that was going to be difficult. So, and then within about 2 or 3 points, sort of an uneasy feeling developed, because nothing was coming back. So I carried on a bit, and then when I got to the most challenging bits, which were there were legitimate concerns that if things didn't change, that there was going to be a vote of no confidence in the midwifery management. So when I got onto that bit, it was obvious that the head of service was then becoming upset, and she grabbed, I remember she grabbed her mobile phone, she grabbed her handbag and said, "Oh, I think the best thing to do then is to tell these people to go ahead with a vote of no confidence." And she left the office. And I remember sitting there looking at my watch or clock, thinking that I wouldn't have predicted that. And I was chatting to her in exactly the same tone as I was chatting to you. I wasn't aggressive. I didn't use strong language. The tone of my conversation was professional throughout, which of course was then completely turned around against me when the accusations against me were, including apparently I blocked her exit to the room, which was ludicrous. So I went to my office, sort of scratching my head, thinking, well, I completely misread that. And then within a few days of that meeting, I was contacted by my clinical director, my divisional director, and I had what I thought was going to be a challenging meeting with the clinical director, and he just wanted to know what my concerns were, and a bit of a chat about the nature of the discussion that I'd had, and that was ended up quite amicably, even to the point that afterwards, at the end, he said, "Well, look, I think what we should do is, I would like to use you as a sort of a sounding board for obstetrics." He was a breast surgeon, but he was our clinical director. How about we set up sort of an informal regular meeting? I said, yeah, that's fine. And then a few days later, I met with the divisional director, who was very much sort of in the background, and had a similar chat. And then it developed into quite a weird atmosphere in the department, primarily because none of the midwifery managers seemed to come down to Winchester for a couple of weeks, which was really odd. And then there was a sort of uneasy feeling that things were developing. And I remember contacting the BMA saying, look, I haven't got anything specific, but I just think I'm being set up. Can you give advice? So they gave very helpful advice. And then There was a guideline meeting, so I and a senior midwifery colleague had rewritten the fetal monitoring guideline, which I knew was going to be contentious because we were recommending a significant change in fetal monitoring practice. The remit and the basis for that was that there was evidence coming out of the States primarily that if you increase the level of monitoring of babies that you thought were low risk, and they actually weren't, and my theory was that if we offered mums to have a CTG, irrespective of their risk status when they came into the unit in labour, you might just pick up the high risk baby that we'd missed during the antenatal period. But I knew that was going to be contentious. Normally, other guideline meetings, you'd have half a dozen people in. Most people didn't really show any interest in them. The guideline would be ratified, it would go out, comments would be made on it, and then it would be finalised. But this meeting, there were about 40 people, and they'd all come down from Basingstoke. A lot of the more pro-normalisation midwives from Basingstoke came down, and interestingly, the head of service was there, her 2 deputies were there, and one of the consultants from Basingstoke was there, and it degenerated into the most aggressive, unprofessional assault of any consultant I've ever seen. So I presented the guideline along with one of my midwifery colleagues, and it became perfectly clear that this was there had been a 3-line whip from the Basingstoke end to basically try and goad me. And about halfway through the meeting, I thought, this is futile, this is a complete waste of time. So I just sat down and didn't react to it. What I hadn't realised, but I found out afterwards, that when I'd left the room to go to the toilet at one point, there was continuing verbal abuse about me when I wasn't in the room, which was pretty unpleasant. The very weekend after the guideline meeting, I happened to be on call on the Friday evening, and we had 2 supposedly low-risk midwifery cases, so cases that as obstetricians we were not expected, not wanted to get involved with. And so these were low-risk first-time mums, and we had one baby that was essentially born dead, and another one that was born alive, who then crashed spectacularly within a couple of hours and then subsequently died. Now, the one that was born dead actually was then resuscitated and actually did okay, I believe, but the other poor baby, obviously, that died a couple of hours post delivery, didn't survive.
Yeah. And Martyn, in the midst of all of this, at what point did you feel that your career now was starting to become at risk?
The Datex reports on those 2 cases were put in. The head of service would have seen that, and I think thought these are exactly the cases that he was talking about. We need to get him out. This needs to be jumped on.
Yeah. And how did they set about that?
Well, what happened then was this meeting that was provisionally timetabled with the chief medical officer, I couldn't make. I politely declined, asked for it to be rescheduled. 2 or 3 weeks went by, didn't hear anything, and then one Wednesday afternoon, I got another invite from the same PA saying, "Oh, I know it's short notice, Martyn, but would you be able to attend the meeting at 4:30 on Friday, so 2 days' time?" Which, of course, I now realise the 4:30, 4:45 Friday afternoon is a deliberate ploy, with a divisional director who, again, somebody I'd never met before, and this is to discuss the communication issues in your department. So, following on with advice from the BMA, I said, "Can you please give me what the allegations are in writing, and can you please tell me whether this meeting is formal or informal?" And I was told, "No, we don't want to give you details of what the allegations are in writing. We'll tell you on the day." And it was just the way it was said. It was the meeting is informal. Pause. But you might want to bring a senior colleague with you. So I ended up taking an anaesthetic colleague with me. So I remember walking across the car park 2 days later, thinking, "Oh, this could be quite positive, because this is a divisional director from another division. They're clearly interested in trying to sort this out." So we waited for a few minutes outside the chief medical officer's office, went in, and then I looked at this round table where we sat down, introduced to the divisional director and her PA. And I looked on the table, and there were beautifully presented plasticized folders, and I thought, this isn't an informal meeting. So the divisional director said, "Oh, Martyn, we called you over because we've received formal complaints from the head of midwifery and a group of her colleagues, and this is the launch of a formal investigation regarding accusations of bullying, harassment, and undermining behaviour about you. But then I was kind of pressurised to sign the terms of reference, which I'm not signing anything until I've had a chance to read them. And I remember thinking, oh my God, this. I was thinking, what on earth have I done to?
So this is where it gets really serious, isn't it?
Oh yeah. So in that sort of 3/4 of an hour meeting, I was thinking, what on earth have I done that justifies this? So I was then sort of told what that would equate to, that it would be a funny 6-week investigation period. We'll appoint a case investigator. The divisional director said she was going to be my case manager.
And were there any restrictions on your work in the meantime?
Yes, but they were imposed by occupational health, really.
Right.
So I was told that we realise this is going to be really difficult for you, so we've made an appointment for you on Monday to see the occupational health consultant. So I remember saying, just out of interest, obviously I need to read this, but what are the best and worst scenarios here? Because don't worry about the worst, because I can imagine what that's going to equate to. But if this all proves to be vexatious and fabricated, and almost before I was finished, the divisional director sort of looked at me, and it was just a look on her face. She said, it was almost as if, well, that isn't going to happen, is it? It was, well, obviously, in the event of that happening, then we'd need to investigate that and deal with that appropriately.
So this investigation took place. So a 6-week investigation, did you say it was?
Well, it was meant to be, but the terms of reference have been deliberately worded to catch me out, because one of them was the third term of reference was to investigate why the previous attempts to modify my behaviour have been unsuccessful. And I said, well, I'm not accepting the wording of that because there haven't been any previous attempts. So that was reworded. Then the case investigator that they appointed was a close working colleague of the principal complainant. So I said, well, I'm sorry, I'm not having that, and the BMA backed that up. So they then told me that they didn't have any other investigators. So they refused to appoint somebody from outside the trust. So they then had to train a stroke physician. So she rapidly went off on the course to train to be an investigator. So she finished her training on the Thursday and commenced my investigation on the Monday. And that went on for, the MHPSI, the Maintaining High Professional Standards investigation, was launched in May of 2019. And I didn't get back to my full job until late September of 2020. Right. So the occupational health consultant, who was incredibly supportive, she'd clearly seen this sort of thing before in the trust. She advised, which was quite appropriate, that I shouldn't work in any clinical environments where I could see my complainant. So I wasn't allowed to work in Winchester at all. So I was purely allowed to work in a little sort of peripheral hospital in Andover. So no labour ward, no on calls, and I did a few outpatients clinic, a scan list, and a hysteroscopy list.
I mean, when did you end up having to stop working? Essentially, what happened then?
Well, I eventually got back to work. The allegations against me were not upheld, despite the trust retrospectively claiming that wasn't the case. That wasn't good enough, though. The trust decided that they wanted their pound of flesh, so they said there were clearly communication issues. So I had to go on an advanced communication course. I had to go through a mediation session with my 2 remaining complainants, which all that succeeded in doing, because that was at a time when I was at probably my lowest. That just precipitated me into an acute depressive crisis, needing GP, psychologist, psychiatric input and medication. I eventually got back to work in late September, and it was perfectly clear from the first day I went back that I was being invasively monitored. Every single procedure I did, every single interaction I did, every telephone conversation I had, particularly if it was involving any of the senior midwifery managers, was being monitored and was being escalated. And that was a really uncomfortable feeling.
What ended up with you essentially leaving or being dismissed? I'm not quite sure which of the 2 it was.
There were several. One of them was one afternoon I was on call with a middle grade, and she did a surgical procedure without telling me and caused a complication to the patient. And I was called in as an emergency, having not even known she'd done this procedure. And apologised to she was a young lady, apologised to the lady, explained what had happened, and she needed to go to theatre. Now, my job had changed against my wishes, so I wasn't doing minimal access surgery at that time. So, and had been for 10 years that had been agreed with my other consultants. So I arranged for one of my junior consultants who was AS trained to stay on after work. We both did the surgery. So I assisted, and it was straightforward, absolutely fine. But the corollary of that was it gave the trust the ability to claim that I was no longer capable and skilled to be on call anymore. And I challenged that and got the BM onto it, and that failed. So it was essentially like being downgraded to a registrar.
Right.
So with the BMA support, I ended up putting in a grievance, and this all took time, and it was whilst I was still working. I put in a grievance. I managed to convince the chairman of the trust that an independent external investigation of how the trust that managed my case should be undertaken. His understanding of independence was certainly very different from mine. So that really wasn't really worth the paper it was written on. Yeah. So we eventually, again with the BMA support, ended up taking the trust to an employment tribunal for whistleblower persecution.
Yes. And so right. And did you actually resign, or were you asked to?
No. It was so the grievance went in. The parts of my grievance were upheld by a very integrous ex-military non-executive director. So I thought, oh, actually, I'm actually getting some leverage here. But then the chief executive, who was very heavily involved with other sort of egregious aspects of what I'd highlighted, what was going on in the trust, and the chairman, basically overruled him. So in July of 21, when I had what I thought was going to be my grievance appeal conclusion meeting, that was extended into the chief executive claiming at that point in time that a committee which I'd actually advised her to set up back in 2019 when I met with her to say what a mess the handling of my principal investigation had been. I'd advised her to set up what became called the Professional Standards Advisory Group. So that committee had met and had decreed that my relationship with the trust senior management had irretrievably broken down. So that was levelled at me. And then if that wasn't bad enough, and that committee had actually recommended to the chief executive to dismiss me, which was way beyond their terms of reference or remit. And that committee was chaired by none other than the chief medical officer, who was my case manager for my disciplinary hearing. And then if that wasn't bad enough, the chief executive then said that it had been decided that my potential return after that meeting to a job that I've been doing for sort of 16 years and have been doing since I'd gone back, my return to the department could, quote unquote, pose a significant risk to patient safety. That was the classic Darvo turnaround, that I'd raised patient safety and staff safety concerns, and here we are 2 years later, the chief executive accusing me with a complete, in her own words, a completely exemplary clinical record with not a single adverse clinical incident ever attributed to my management at any point in time of my consultant tenure.
Yeah, just to elaborate on that for listeners, you've just referred to Darvo. So this, of course, is deny, attack, and then reverse the victim and the offender sort of ratio, isn't it? So what ultimately happened? Did you resign, or were you dismissed?
No, I was dismissed. So they then appointed another company whose name I won't mention to conduct another investigation to basically prove or disprove whether my relationship with the trust senior management had broken down. And they were paid a vast amount of taxpayers' money to basically to deliver a narrative, and it was the most corrupt and deceitful investigation. But of course, it delivered exactly what they wanted. So I was eventually dismissed under some other substantive reason, which is the grey legal area, which is used by clever employment lawyers and barristers to dismiss.
While all this was happening, and these investigations and grievance hearings and disciplinary hearings were all being managed by the trust, either directly or notionally independent through the non-exec, was there anyone outside of that, whether it was the then clinical commissioning group, or it probably predates the ICB, or the regional office of NHS England? Was there anyone outside that was looking at this?
That's a very astute question. What they did with my case was to refer it up to the branch of NHS resolution called PPA, So they use them, and they seem to do this and they're continuing to do it. I understand they use that almost as an insurance policy. So I was told, oh, we've run this stage of it past, and it was the same individual at PPA, NHSR, and they support what we're doing. When I had my dismissal hearing, they pulled in a couple of tame medical directors from other local trusts, who, I mean, again, it was the classic conflict of interest, in that we managed to prove that at least one of them had a previous close working relationship with the trust chief executive who chaired my dismissal hearing.
All these people that were coming in, did any of them ever sit down with you and say, Martyn, from your words, tell us what's been going on?
No.
Was there?
No, they weren't interested. No, they weren't interested. It was I was a troublemaker. That they needed me out, and the only people that they consulted and got involved were people that were. The financial side of it's pretty condemning, really. I mean, they did 3 supposedly independent investigations into me, which cost a vast amount of taxpayers' money to do, and they became increasingly corrupt. So they just delivered what they were asked to deliver. Nobody was interested in the truth or my side of the story. And I was eventually dismissed on the basis of 5 individuals saying to the trust and to this external consultancy that they weren't prepared to work with me anymore. And not only that, but they were not prepared to go through any kind of facilitated mediation to see if they could work with me. The problem with that was that all of those 5 individuals were entirely conflicted. So one of them was the chief medical officer, who had been so deficient in her handling of my case. Two of the 5 were 2 of my original senior midwifery complainants, and the other 2 were 2 consultant colleagues that I had separately whistleblown about a tragic maternal death case that they were both involved with. So it was hardly surprising that they were keen to jump on the bandwagon to also get me out of the door. And even that's a prime example. There were 5 individuals that got me dismissed. And when I said to that investigator, because I worked out probably about 400 other individuals that I reckon I work with on a relatively regular basis, and I said, why aren't you interested in their opinion? I think they would be aghast if they knew you were going to dismiss me. So why is it the opinion of 5 entirely conflicted individuals that you're basing your decision on dismissing me?
Now out of work at this point. This was what, 2021-ish?
I was dismissed in March of 23.
23, sorry. And actually, haven't you worked since then, Martyn?
No.
Right.
And I haven't for several reasons. It's I mean, as you know only too well, Peter, as soon as you get labelled as a whistleblower, then you are forever. It doesn't matter whether you did it with good intentions for the right reasons or not. That doesn't matter. So there was that aspect of it. The other aspect was, of course, having been accused by the chief executive of being a risk to patients, and I'm still waiting, and the BMA is still waiting for the evidence for that, because there never was any. I effectively was, I haven't done any clinical practice since the 9th of July 21. I carried on my private work for a bit, but then of course that all dries up.
Yeah, absolutely.
So I then stopped that in May of 22, primarily because I was doing so little, it was commercially non-viable. And I also thought, well, I'm doing so little, if I have any complications, I'm going to be heavily criticised.
Yes.
So, and then the third reason was, of course, I'm sure you experienced it to a degree, Peter, is the way it affects you psychologically. Because before all of this, I used to love the cut and thrust of an acute labour ward. Nothing would faze me. The worst placenta previous sections I would thrive on. Mm-hmm. And I'm now at the point if I just watch medical dramas on the TV, I come out in a cold sweat.
Yes, I can empathise with that.
It is absolute. So I don't think I would even get close to even being able to go back to frontline obstetrics, which is a pretty sad day, really.
It's a terrible waste, isn't it? Terrible
waste. But then, I've been in contact with loads of other whistleblowers that are 38, not 48. So sorry, 38, 48, not 58.
Yes.
So as far as my age is concerned, at least I wasn't that far away from retirement, but it certainly wasn't the it certainly wasn't the end, the sunset of my career that I would ever have expected.
Absolutely. And let's move on to the legal protections, because I mean this is an area that interests me as well, because you said it then went to an employment tribunal, so I presume there was the usual sort of 2.5 year wait.
Yeah.
And just fairly briefly, I mean, what is your opinion of the Public Interest Disclosure Act and the protections for whistleblowers like you and me and hundreds, if not thousands, of others?
It isn't fit for purpose. It was perfectly clear. My case, like so many others before it, should never have gone anywhere near an employment tribunal. All the Public Interest Disclosure Act does, it doesn't protect the whistleblower. All it does is it gives NHS trusts and the legal professionals that are earning an absolute fortune on the gravy train that this process allows them to manage, to get or to convert whistleblowing into a disciplinary issue. And to this day, I will never understand how my case got into the court and a barrister was allowed to paint the picture of me, which was completely falsified. So in my case, I don't think employment tribunals are ever easy. It was a hideous thing to go through, but I don't think anybody who was involved with it, or the numerous people that were kind enough to actually engage with it, to actually come down to the court or to watch it online, would even be able to get close to comprehending how we lost. I mean, my barrister, who was a very experienced barrister who wrote some of the UK whistleblowing legislation, was absolutely beaming with confidence at the end of it, that we'd won. And the judgment, which occasionally I go back and read now, just didn't in any way reflect the evidence that was presented. But of course, my case closed 10 days before the law was changed to force the employment tribunals to record proceedings. So the big problem I had as far as launching an appeal was on what basis could I challenge the evidence, because there was no record.
Yes.
Pretty much every paragraph of my judgment has got factual errors in it that didn't reflect the evidence that was presented. But when you can't prove that, where do you go with that?
Yes. And also, I mean, one of the things that concerns me as well is the background to all of this is risks to patients, isn't it? And I mean, did anybody on the panel, the judge or the other panel members, show any interest in the patient safety aspects that you brought to light?
No, and they very skillfully, because one of the biggest strengths I thought of my case was the fact that so I whistleblew in the spring of 2019. CQC descended on the trust in late 2021 unannounced, and then put out an absolutely condemning report about maternity services that was published in February of 2022. And every single one of the risks that I'd raised nearly 3 years earlier were brought up in the CQC report, which incidentally I was blamed by the management for calling them in, which I categorically didn't. What
was the role of the regulators in this? Did they get involved? So you've told us the CQC did and very much vindicated your position. Were any other regulators like the GMC involved at any point?
I was told in a rather threatening fashion quite late on in the process. I think it was probably just prior to going to the employment tribunal that I'd been provisionally referred to the GMC by the chief medical officer, who was my case manager. So that never went anywhere, and there was no reason why it would. But yeah, that was done.
Do you think that was if it was just before the employment tribunal, was that an intentional threat, do you think?
Oh, absolutely. It was a shot across the bows. Yeah, I mean, the whole, when I look back at it now, the way the whole process was managed by the trust was it was identical to your case, Peter. It was to break you. I mean, it was protracted. It was drawn out. The deadlines that were repeatedly breached. The making contact or sending emails at 5 o'clock or 5:30 on a Friday evening, knowing that you wouldn't be able to contact your BMA until Monday. They wanted to break me, and they did pretty well. They came pretty close in the winter of 19 into 20.
And it's a well-recognised tactic, isn't it? Referring somebody to the regulator. I think it happens
absolutely.
with colleagues as well, that they get referred to the NMC.
Absolutely. And if you add on to that the imposed professional isolation, particularly during the initial investigation, just before I left the office with my beautiful plasticized folder of complaints, I was told, oh, by the way, you're forbidden to contact anybody in the trust to discuss anything about this, and if you do, that will go against you. So, because of course, the one thing you want to do in this situation is to go to your nearest clinical colleagues and say, you won't believe what's just happened. And of course, they then are being gaslit information about you. So these people that you thought were your closest clinical friends and colleagues suddenly just back off. Yes. And of course, they're scared because they don't want to be seen to be in Team Pitman.
Yes, and that again leads on to a question I was going to ask you, which is what happened to your sort of peer support group and, the sort of colleagues that are friends and that we all rely on to sort of keep our morale up and so on.
Over time, Peter, pretty much completely disintegrated. Yeah. A couple of a retired senior consultants been very, very kind and supported me. He gave evidence in the employment tribunal. The junior guys, many of whom I played a role in training them as registrars, and also played a role in promoting them to get them into Winchester as consultants. That was really hard because eventually, one by one, each of them dropped off. But then there was this realization on my part. I thought, well, of course, the reason they're doing this is they're scared because they don't want to be the next.
Yes.
So they don't want to support me. They don't want to say, actually, either individually or one would hope collectively, we don't think this is right, because they'll be the next out the door. Because you do realise, as I'm sure you did, Peter, that even as a senior, respected consultant with an absolutely apt in your case, and I think without being arrogant in mine, with exemplary clinical standards, that doesn't mean anything as far as the trust management are concerned. You are completely expendable.
Yes.
So we'll get shots of him, we'll put an advert in the BMJ and we'll replace them. The problem with probably the same with you, but with my cases, here we are now in August of 24, having been dismissed 18 months ago, and they can't reappoint to my post.
Martyn, just opening this out a little bit more, because obviously we're here to try and learn from this and see what can be done to stop this kind of thing happening in the future and patients being put at risk and so on. I mean, first of all, I think you've pretty clearly laid out the sort of culture that existed at the time, which seemed to be one of essentially forcing units together for presumably financial viability reasons, and then not addressing or attempting to cover up the safety issues that came out of that. I mean, how do you think that sort of culture, do you think it's widespread across the NHS, and how do you think it should change?
I think the merger side of things is you only got to look around the country to see what happened at Winchester and Basingstoke. The formation of a bigger trust under the Hampshire Hospitals Foundation trust status is very common. I think probably most of those mergers have probably happened now, and I'm not aware of many that have been smooth. The whole culture around what happened to me, I think, is probably fairly ubiquitous across the NHS. All I did was I undertook what was my basic clinical responsibility, but I also had a moral responsibility to do it. So until you can introduce a system, because freedom to speak up has clearly been an abject and a very expensive failure, until you can introduce a replacement to that which genuinely protects the person that's been brave enough, or in my case, maybe stupid enough, to raise the concerns, then I don't think the situation is going to improve. So you need to have a system where, as the whistleblower, you are genuinely protected and you're kept anonymous. And that can't work in an NHS organisation where the freedom to speak up guardians are employed by the trust. So in my case, my freedom to speak up guardian's line manager was the person that I had gone to raise concerns. So how can that possibly work? So with serious issues like what I was raising, like what you were raising about patient safety and staff safety concerns, then the only way it can work really is if you have an organisation outside of the trust that you go to with serious issues, and then they take over the investigation. So you, as the whistleblower, are entirely protected rather than victimised, persecuted, and hung out to dry like you were, and like I was, and like a myriad of other people that have gone before us and and tragically are still going through the mill and the completely corrupt and broken employment tribunal system.
Yeah, one of the questions I'm always asked is what lessons can be drawn from this, and I mean, I presume you would do it again, because you would. I mean, that's always my answer, because you've got a clinical duty to do so. But how differently would you do it? What would you change about the way you set about it?
I've been repeatedly asked, surely you, looking back on it, you just keep your mouth shut and you wouldn't do it again. And I will answer your question the same way I've answered everybody who's asked me before, Peter. And yes, I would do it again. Mm-hmm. I've got no regrets for what I did, and the fact that it was later vindicated by CQC backs that up, really. But did I realise what I was getting into? No, I had absolutely no idea on that Thursday when I drove to work that morning. I had no idea what I was getting into. So what would I do differently? I would do a heck of a lot differently. I would never go into a meeting on my own. I would make sure that every single meeting of this nature is recorded, minuted, and the minutes are signed off by both parties. When you've got a legal system which is thriving on earning a vast amount of money by very, very dubious tactics, then the whole system needs to be shaken up and the legislation around it needs to be changed. And these cases shouldn't go through an employment tribunal. It needs to be handled through a completely different legal process. And that's why, I think what you're doing, Peter, and what I'm hoping to do to because I'm shot now, I'm clearly not going to get back into clinical practice, but I hope and think I've got a role in advising people that end up in similar situations to where I've been. But also, I'm absolutely determined to try and change a system which is so obviously corrupt and broken, to try and prevent others from going down the same tragic route that you and I have gone down. And it's an absolute travesty for the NHS that experienced people like you, me, and all the other people that are falling by the wayside are being lost to the service, and particularly in maternity. Sure. I mean, it's just staggering that every time you pick up a newspaper or see the news, you see another maternity disaster, and there you've got somebody with 30 years experience with, I'm told, exemplary clinical standards, who's been dismissed for what? Not for gross professional misconduct. Oh, no. Dismissed not because of what I said as a whistleblower, but I was dismissed because the way you said it. Yeah. Really.
And I'm going to ask you now, I always used to struggle with this question when I used to do presentations, so I'll bounce it off you. But on three levels, really, how would you wish to see things changed in the future to stop this sort of thing happening to whistleblowers like yourself? And I would put it on the three levels of what would you like to see happen on a sort of NHS organisational level, on a regulatory level, and on a legal level?
Well, I think if I go backwards on a legal level, I think I touched on it already. I think these cases have to be taken. You have to remove the ability for the legal system to convert whistleblowing into a disciplinary issue. So take them out of the employment tribunal, and there has to be a separate legal process.
Yes.
From a legislation perspective, clearly that Peter has demonstrably failed and needs to be replaced. And new legislation needs to come in to replace that, because it isn't protecting the very people that need to be protected, the whistleblowers who are brave enough to raise the concerns about patient safety. So that needs to be radically changed, and as soon as possible, to prevent other careers and lives from being destroyed. And from a local perspective, I think, as I've already said, freedom to speak up at a trust level has failed. So the freedom to speak up system needs to be radically reformed and changed, and actually do what it was initially designed to do, to protect whistleblowers and to protect patient safety.
And the regulators, because I feel quite strongly that the CQC and the GMC both purport to actively support whistleblowing. In fact, the GMC makes it part of our registration, doesn't it? It is mandatory that we speak out on behalf of patients if we see harms being done. Yet, certainly my perception is there's very little support from the regulators when people like you and I really need it.
Nothing. They're spineless. And the same as, the stuff that's coming out about the NMC, and it's the same, isn't it, really, that they're not they're not providing the level of support and defence that we would all expect. And ultimately, I mean, the stuff that Wes Streeting was saying before the election is potentially really positive. And he went on record as saying that any senior NHS manager who persecutes and victimises a whistleblower will be dismissed and will never work in the NHS again. I just hope that the accountability that threat should entail comes to fruition, because that's what needs to happen. Because certainly in my case, and I'm sure yours and many others, there are managers that have behaved absolutely despicably and egregiously in destroying careers and in destroying lives, who just get away with it and just get recirculated, and there is zero accountability.
If people that have behaved in this way and have targeted yourself and Peter, and the parallels between your experiences are so, sitting here listening to having listened to you and talked to you at length before, Peter, the parallels are so obvious. But what do you think their motive is?
I'm sure it's the same in Peter's case as mine. It's the mistake I made was to challenge individuals who were incapable and unwilling to be challenged. And as soon as you get into the realms of reputational threat, be that on an individual basis as a manager, or even more so as a board, and even more so as an organizational threat, then you're on a sticky wicket. I started to press pretty vulnerable buttons for the chief executive, the chairman of the trust, and other members of the exec team. And as soon as that happened, that was when the playbook, because the reason my story sounds familiar to Peter's is that there is a playbook that is used with all of us. I go as far as to say that the chief executives probably consult each other about, we've got this problem. What did you do to get rid of Peter Duffy? I know there are legally run seminars that some senior NHS managers go to, specifically designed for this sort of issue. And there are organisations out there, and I know of at least 3 that are involved in my case that are earning vast amounts of money by delivering narratives that NHS Trust asks them to deliver to dispose of troublesome individuals. So if you look at what they could have done, should have done with my thing, which would have been to have addressed the concerns. That would, on the face of it, seem to be very easy. But by doing that, they would have had to admit that the course they had taken since the merger had been wrong. They weren't prepared to accept that. They weren't prepared for the reputational damage that would come from that. So I'll tell you what we'll do. We'll take out the messenger. And you suddenly become an expendable little chess piece on a big chessboard. So they just flick you over, and there you go.
It's an interesting reflection, the projection that is exactly what they were accusing you of, which was not communicating effectively or behaving appropriately, and yet actually holding a mirror up was what they were challenging you with. Was how they were behaving.
As I said to them repeatedly throughout my investigation and legal case, I said, I had 28 years of annual appraisals, which were exemplary. I passed through 2 GMC revalidations, the most recent one signed off by the very same chief medical officer who then decided to investigate me. And that was signed off with glowing tributes 2 months before they launched their formal investigation into me on the basis of communication and relationships with colleagues. And then when I cut and pasted those very sections from my GMC revalidation from 2 months earlier, the gradings for relationships with colleagues and communication were the highest gradings they could possibly have been. And when I said, it doesn't really stand up to scrutiny, does it? You've got a very small number of midwifery managers that are making these accusations against me, but it doesn't stand up to scrutiny because I presume you've looked at my appraisals and the revalidation that you signed. And do you know what? How that was fed back to me? Your revalidation and appraisals are irrelevant to this process. So why do we spend months doing them? Well, what's the point? they're irrelevant. So they're irrelevant because they don't back up the narrative on me that you're determined to prove. So they were never even discussed in my employment tribunal, and yet this barrister was determined to paint me out as being an absolute tyrant, an ogre, a serial agitator was what I was accused of being, which he later retracted.
Yeah, well, I think you've sort of drawn out a point there that I was going to make, which is, you were, I think, sort of accused of being robust, let's say, in speaking out. But then, when you have young mothers and babies being put at risk and, potential disasters heading down the pipeline towards you, I would say, how can you not be forceful? You would not be doing your job if you were not forceful and outspoken. So I did find it astonishing, because I remember your case appearing in the press, that you'd been accused of being too forceful. If you hadn't spoken out robustly, I would have said you probably were not fulfilling your regulatory duties.
Yeah, and when you look at that at a local level in the trust where I was working, but then if you take a step back and look at it globally across the country, Peter, and the Morecambe Bay, the Shrewsbury and Telford, the Combe Taff, the East Kent, the Nottingham, and you think, well, maybe if consultants in those units had actually spoken up, and God, dare I say it, spoken up robustly about what was going on in those units, rather than clearly burying their heads in the sand and just letting serial disasters occur, then maybe some of those disasters would have been prevented. But I completely agree with you. I don't understand how any clinician of any seniority could observe babies and mothers being harmed or worse, and to speak in what mellifluous, gentle terms. I don't get that, when lives are being threatened and damaged and families destroyed. Yes. I don't understand that. But again, it was an easy thing to say without any evidence to back it up, and it's a pretty emotive thing to challenge.
I just wanted to pick up. I mean, Peter, I remember talking to you, and it's in your books, about the relationship with families, and in preparing for this interview, reminding myself of the employment tribunal and the press that came out at the time, Martyn, because I followed it avidly and was very shocked with the result of the employment tribunal. But all the way through, as I've sort of Googled your name, testimony upon testimony comes up from patients and families. I mean, the patient and the family community have always been supportive of you, have they not?
Oh, incredibly, and even in your darkest day, because there've been some pretty bleak moments since the judgment came out. The level of support from the Facebook patient support group that was set up by an ex-patient of mine has been incredibly humbling. And you do kind of reach the point where you think, well, actually, who is it that, if you take away the sort of the career destruction and financial Armageddon that presents when this sort of thing happens, and you think, well, actually, whose opinion matters the most as far as what you are like as a person and as a clinician? Because show me any patient complaints that happened about. So if I was this tyrant that I was painted to be, then I did pretty well to hardly have any patient complaints in one of the highest stress, highest risk specialties in medicine. So those individuals, those 2,000 odd patients that posted incredibly humbling and touching and heartwarming tributes about me as an individual and as a clinician, it's them that matter at the end of the day, far more than a handful of legitimately challenged senior NHS managers who decided to take me out and to end my career and to damage my life.
Helen, was there something else you were going to ask?
No, when you're making your concluding comments, I just wanted to make sure that my thanks are expressed as well, Martyn. So appreciate you giving your time and sharing your experience again. And I hope it's not giving you more PTSD, having to relive what's obviously been a very painful process.
I still find it quite cathartic to discuss it, and particularly with people like Peter that have been through it, and you do realise actually that a lot of what we've been through is the same. And that's why I think, you know, collectively we've got so much to offer other people that are facing similar traumas. So no, I'm very grateful for you giving me the platform, for listening.
Thank you very, very much. Well, Martyn, I'm so sorry this had to happen, but you know, thank you for giving your time up, and I'm sure we'll meet again in the future, probably several times.
Helen, soon.
Helen, thank you so much again for giving us the platform, and thanks as well to Lottie in the background, who's now got all
thank you both,
sorting this out, and we'll look forward to the next video shortly. So thank you all very much.